So I think we're going to get started. Welcome. Thanks for joining the Baltimore County Fire Department EMS Academy training series. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active volunteer at Pikesville in Baltimore County, and I have the honor of serving as Associate Medical Director of the Medical Director's Office. On behalf of the Medical Director's Office, on behalf of the EMS Office, Director Shenning, Captain Willits, Captain Stewart, Captain Natz, thank you so much for joining. Thanks for what you do every day. Thanks for your dedication to lifelong learning. A big shout out to Ashley Brooks, who is online, one of our young members who is helping us to manage this Zoom meeting. I would point out in terms of the Zoom platform, a couple of functions. Number one, in the bottom left-hand side of the platform is mute, and we do ask you to mute yourself. You're welcome to unmute yourself if you have a question. Keeping us on mute really helps with the background noise. I defer to you, but I think good etiquette also recommends that we stop our video, at the bottom left-hand side of the platform if you're not talking. One suggestion around these meetings is to stop the video. That way it prevents us from, just being pulled into everybody's little window and watching people rather than staying in the present. I also find it quite helpful.
Stop my video?
Not you. On the upper right-hand side, there's a screen view, which I think is also helpful. There's a gallery view and a speaker view. I defer to you on how you want to do it. I want to make sure you know that that option is available. I personally like the speaker view because that means whoever is talking comes into the main picture, and then the rest of the participants are up above. I would also draw your attention to the bottom of the platform is a chat function, the chat function. The chat function, a couple of things are going to happen. Number one, if you have a question for Dr. Kirschner, we are asking that you either chat the group or you're welcome to chat me, Sean Barinholtz, your host, and then I'm happy to share these questions when it's time for questions. In the past, folks have chatted with Dr. Kirschner directly, and that turns out to be a bit distracting and difficult for him to manage. As would any speaker, trying to deliver content as well as managing the chat. So that's challenging. So again, I just ask that you chat either everyone or you're welcome to chat with me privately. Certainly if I read out your question, there will be no name identifiers. So I think that that's to maintain your protection and privacy. I also would comment for the chat function that this is a great way if you're interested in getting your CEUs. Ashley will be sending a link to that chat midway through or so where you can copy that link. Unfortunately, Zoom does not allow you to click or cut and paste the link out of the chat function anymore, but it is a short link. If you copy down that link and go into the web, you will have access to a sign-in sheet so we can make sure that you get your CEUs. If you're a company, particularly a career company with a bunch of people in the room, I do believe that Captain Stewart has reached out to you via email, and you guys can organize a way to get your continuing education credits for participating as well. If there are any other questions, feel free to chat. Feel free to send me a chat. Today we're super lucky to have Dr. Dean Kirschner with us. Dr. Kirschner is a licensed clinical social worker and mental health clinician specializing in mental health trauma. Dr. Kirschner has worked in the area of mental health for first responders for almost 30 years now, and he is on 5 Schism teams, including the Baltimore County Fire Department Schism team. I've also learned many other interesting things about Dr. Kirschner and his generosity. One thing I will comment is that he's almost finished his EMT class, which is quite exciting. Dr. Kirschner, as always, thank you so much for being with us, sharing your time, sharing your tremendous amount of expertise, and taking care of us. Thank you.
Good evening, everyone. So, as Dr. Sean said, if you would please, I know many people in the fire department, and I think just about everyone seems to have my cell phone. So please, I'm going to ask you, if you would, if you've got questions or something you want to share, please do it through the chat and not through my cell phone, because I did turn my cell phone off because it was very distracting last time when I was getting all of the messages on my cell phone. This evening, my plan is to talk about suicide from 2 different perspectives. The first is from the perspective of what may lead to someone being suicidal. Um, what are some, maybe not predictors, but some variables associated with suicide, and going through different um, aspects of suicide. And then we're going to end with, if you know someone who has committed suicide, how to take care of yourself or how to take care of someone else um, who has been the suffering person who has lost someone to suicide. Again, I do welcome your questions. I welcome your input. So please contact Sean or Ashley, and they will help us get that together. Let me start by saying that suicide is a desperate attempt to get away from something that a person perceives as just unbearable. Suicide is associated with depression, but let me first start by explaining what I think depression is. There's two different feelings, depression and anxiety, that people talk about. Depression is the feeling of being stuck, hopeless and helpless, feeling of not being able to get out of something where you don't see a way out. Often a person who is depressed is experiencing some type of anger that is pushed down deep inside, and they don't have a way to express it, some kind of helplessness or hopelessness that they have stuck deep inside, and they don't have a way to get it out. The person who is depressive, suicidal, often has sort of blinders on. They can't see the larger picture. Their focus has become very narrow. Before everybody went to video off, I saw one person had a beautiful picture of two horses that were lying on the ground, and that reminded me of sort of a person who is suicidal or who is in that depressive place, when horses have those blinders on and they can't see. There you go, someone has that, but they don't have the blinders on. But when you see that type of inability to look at the larger picture beyond that feeling of hopelessness and helplessness, that's what happens with people. They are sort of stuck. It's almost like the brain has been frozen. Those of you who are EMTs are probably familiar with some of the brain structures associated with feelings, the amygdala, the hippocampus. These are where feelings are located. When you hyperstimulate certain parts of the brain almost like shuts down. You've heard of the term scared speechless. Well, people who are in this depressive place, their brain almost shuts down. They don't have that ability in that place to see beyond this hurt that they're experiencing. And suicide is just that. It is a desperate attempt to stop the hurt. You will hear people say that suicide is a permanent solution to a temporary problem. Now, we want to be careful saying that to someone. Oh, listen, you just have a temporary problem, but because that feels dismissive. So we don't really kind of put it that way. And we'll get into some ways of talking to someone who may be in that very unfortunate place of being depressed and feeling suicidal. But it is a permanent solution to what others of us might see as a temporary solution, a temporary problem. I do want to let you all know that Chris Santoro, who is the director of the Schism team for Baltimore County Fire Department, as well as the entire Schism group, has put together a wonderful presentation on suicide. It is a PowerPoint. I'm sure this video this evening will make its rounds, but as well, you can request from the Schism team that PowerPoint, which I know I've seen, I've been involved in its creation, is actually quite well done. So moving on, people talk about depression as a chemical imbalance. There are different chemicals, we call them neurotransmitters, involved in depression. You've heard of selective serotonin, uptake inhibitors, SSRIs. You've heard of tricyclic antidepressants. These are ways to sort of get the brain engaged again in less depressive model thinking. I won't get into a whole neurochemistry because we might see people get rather bored and start dropping off with that, so we won't do that to you. But regardless, the brain does get sort of stuck. Think about those of us who are a bit older might remember vinyl records, and you on a record. You're muted. I'm muted. Okay, you're muted, Chris. Somebody just say they can hear me because my computer said
You're good.
I'm good.
You've been
Okay,
on mute for like 2 seconds and you're off.
okay, so I'm back on. All right, sorry if I missed anybody. My computer said I'm muted, but thank you. So moving on, a person is stuck in these feelings, sometimes of self-loathing, sometimes hopelessness, sometimes, and I'm going to be very careful with this next one, perceived isolation. I know we are doing this social distancing. I like to call it physical distancing because we're really not socially distancing. We're talking to each other, we're talking to friends, we're engaged with other people. So, but when a person feels isolated, when they don't feel they have some place to go to express their feelings, to be connected, that isolation leads to depression, which can lead to suicide. Please keep in mind, not all depressed people are suicidal. There is a portion of people who are depressed who are suicidal, but not everybody. Just because someone's depressed does not mean they're going to commit suicide. With a suicidal person, they believe, in a sense, there's no way out of their state of mind. They don't have the same logic. For some reason, in some way, their logic gets turned off. And I've had people say to me, you know, didn't they realize they were going to hurt their mother, their father, their children, their sister, their brother, their spouse? That's not where their head is. They don't have that sense of logic. If they had that logic, they wouldn't be thinking of hurting themselves. So their logic is failing them. It's turned off. It's not working. Their brain mechanism, that is the logical part, the front part of their brain, isn't working. Now, we do have ways of trying to get that front part of the brain engaged again. It's not fatalistic when a person gets into that mindset. That's why we have therapists. That's why sometimes there's hospitalization or medication to try to get them to that place where we can turn that logic back on, not keeping it shut off permanently. But people who are suicidal, they're deeply convicted. They're very conflicted about ending their own life. They don't want to die. They want to stop hurting. And what we're looking for is how to get that person to the place where we can help them, or they can help themselves, or we can all be together and help that person not feel like there's only one option. There are other options, and we work with those other options, but just keep in mind that that person doesn't want to die. It's just they want to stop hurting. They want that pain to go away. Let's talk about a couple of myths. I have heard people say, don't ask a person if they are thinking of hurting themselves because you might suggest suicide to them. This is not true. I have asked many people, so are you thinking of hurting yourself? Opening the door gives them an opportunity to talk to you, to talk to someone. I don't like when people say, and if you were present in the last time we chatted, I don't like when people say, I'm fine. I'm fine is bug off in other vernacular. But so if someone says to you, I'm fine, listen a little bit more, or work to get them to talk more, or get them to talk to someone, because I'm fine is basically dismissing you. There is every reason to ask a person who has gone through a trauma, who has gone through, who's going through depression, who may seem helpless and hopeless, and we're going to talk about some of the other signs and symptoms that one can see associated with suicide. But it is perfectly reasonable to say to somebody, hey, are you thinking of hurting yourself? You might not have to say, are you going to kill yourself? Sometimes that's a bit abrasive and feels disingenuous. But saying to somebody, are you thinking of hurting yourself, is a very reasonable and, well, highly suggested way of communicating with someone. Another one that I hear is that people who think of committing suicide are crazy, and people who have committed suicide are crazy. They're not crazy. I don't know how people want to define crazy, but people aren't crazy because they want to stop hurting. It's just they don't know how to stop hurting, and they are lost. They're completely out there in a fog and don't know how to find their way out of that. They don't want to die, and not wanting to hurt is not crazy. I think all of us, if we're in pain, either physically or emotionally, we want to stop the hurt. We want to feel better. There's no craziness involved in that. So let's kind of set aside this whole idea of people are crazy. Another one is, if someone says they're going to kill themselves, they're going to kill themselves. There's nothing anybody can do about it. Sometimes it does happen where a person who's going to commit suicide doesn't tell anybody. We don't know about it. We have no idea how to stop them because we weren't involved in their process, obviously, but we didn't see the signs, if there were signs, and we'll get to whether there are always signs. But there are things that we can do if we can identify that the person is feeling scared, threatened, vulnerable. There are things that we can do, and we're going to talk about things that we can do. But we can help a person who's in that dangerous place where they're not able to see beyond the that painful place. We can help them see another place that's not so painful. It's going to take work, and sometimes a lot of work and a lot of getting engaged, being engaged, staying engaged. But let's look at another one, and that is that people who are thinking of suicide don't want help. They don't believe they can get help. They don't believe there is help. They don't believe that anyone can help them. As I said, they're in this place of helplessness. They don't believe there's help. They don't believe there's hope. And often when you're talking with someone, they're going to shoot down every suggestion that you have. It's okay. We still talk with that person because we're still working to get through. Something at some point is going to get through, and we might need the help of medication to help get through. But someone who is thinking of suicide, it's not that they don't want help. They just don't know how to get help. And at that time, in that place, their brain just can't think logically how to get help. So keep that in mind about being there to helping somebody.
Dr. Dean?
Sir.
Somebody writes in, is there a light switch between the amygdala and the prefrontal cortex?
Okay, so what is hypothesized is that when the amygdala gets hyperstimulated, it shuts down different parts of the brain. It shuts down the Broca's area. It shuts down, you've heard of someone saying scared speechless. This is because the feeling center of the brain, when it gets triggered, and triggered significantly, not a little bit, but when it gets triggered significantly, it does have that sort of, that idea of turning off part of the brain. So yes, that is something that we do see. I hope I answered that question for you. There's also the idea that people who are joking about suicide aren't really serious. I take it really serious. Sometimes people will talk about suicide as a way to see whether do they really matter? Do they really, do they have significance in other people's lives? So people will talk about suicide sometimes in passing. If I wasn't here, I don't know that anybody would care. That's a warning sign. That's a message, pay attention, they're hurting. There are times that people will actually abuse that. And it will get to the point where everybody has heard of, oh, what is it called? That story, I can't think of the word for it, where the boy who cried wolf. They cry wolf and no one believes it, on and on and on, until finally they cry wolf and it's really happening and it's too late because no one believed them. I always believe it. When someone is telling me that they're hurting that much, I do want to hear what's hurting them. I want them to talk with me more about it. I want to understand what's hurting. So listen when someone is talking about it. Any kind of talk about suicide or someone saying, you know, I wish I was never born. Somebody might say, you know, if I don't see you again, I wanted you to know whatever. I'd be better off dead. You'd have more money if I were dead. These are people who are giving you messages that their mind is in that sort of illogical place where they're hurting so much that they aren't able to find their way out. And that's when you can talk about it and say, you know, that was really interesting. You just said, if I never see you again, what were you thinking? Are you feeling like you need to hurt yourself? One of the differences is I work not to ask a person what they're thinking when they're in that depressive place. I want to know what they're feeling first, and then I will move to thoughts. It's sort of discordant if someone's telling me they feel sad and I ask them, well, what are your thoughts? Because my thoughts aren't the same as my feelings. So I do encourage people to talk about the feelings, get the feelings out, and then as a clinician, I might then move to, let's talk about the feelings, because I do what's called cognitive behavioral therapy. So I look at cognitive distortions. People who are suicidal, who are depressed, they're having distorted thoughts. And I can help you understand all the different types of distorted thoughts. But a person who is thinking of hurting themselves, their thinking is distorted and their feelings are just distorted. When you see a person who is looking for or talking about, and I'm going to get in trouble with some of my friends here, talking a lot about I've got guns and or I collect a lot of, and I know I'm going to get yelled at from a lot of my friends who collect guns, but there's a difference. Someone who's talking about their guns a lot, and you know, I know how to kill myself. If I had guns, I could do that. These are people who are giving you a message. Someone who says, you know, I know how to save my pills and not take pills, and I know how to do that, or I've heard people doing it. These are people who are giving me a message. I'm in trouble. I need to express my feelings. So that's when my ears start to perk up. You'll hear people, especially in this line of work, in firefighters and EMS, they talk a lot about dying. They talk a lot about the suicide calls. They talk a lot about the violent calls. They talk a lot about the death calls. There is, and be careful with this next piece of information. People who draw often draw spirals, sort of like all the way into the middle. Those are called suicide spirals. Those are one of the things I look for in kids. If they start drawing a lot of spiral kind of stuff where it circles and circles down into the middle, I ask them more about what their feelings were when they were drawing those, because those are indicative of feeling like you are spiraling out of control, if you will, and not having a sense of grounding. Sean, any questions so far? I don't want to keep rambling if there's people asking questions.
Nothing in addition in the chat.
Okay, very good. There are people that don't talk about the future and they feel there's no hope for the future. Again, there's back to that hopelessness. There's no way out. People will talk about things will never get better. Just as a quick aside, this virus that we're all dealing with today, it's going to get better. We're not stuck here. There's going to be improvement. There's going to be a fix. We're not all stuck in the house for the rest of our life. This is going to get better. When people really doubt that, people struggle with that, we have to really look at a person who perseverates or goes over and over and over that things won't get better, and encourage people to see um, things will get better. One of the biggest suggestions is turn off the news, because the news is just this constant barrage of this is bad and this is bad, and it's really not as bad as people want to think it is. So when people are talking about no hope for the future, that's a concern. And in this situation, I know that this situation for everyone right now is very difficult, but it is going to get better. Let's talk about the whole people with low self-esteem, people who get engaged in the helplessness and the hopelessness. More so, they get engaged in the self-loathing. They get engaged in hating themselves, not liking themselves, not liking their body, not liking parts of themselves. People get into body distortion and feeling that their body isn't good enough, their body is imperfect in some way. There are different psychological issues going on, but there's this body dysmorphic disorder when people don't like their bodies and they feel like their body is not the way they want it to be, or they have feelings of shame or guilt or a sense of worthlessness around themselves and their body. These are people who have a higher risk of suicide. And so we want to be paying attention to someone who gets really caught up in that kind of mental processing and that sort of, if I use the word perseveration or rumination, going over something and over it and over and over in their mind. If people...
There was another question.
Go ahead, sir.
Do you see an increase in suicidality with the coronavirus, and if so, why?
Yes. There is an increase in suicidality, both in ideation as well as action. And the reason is that people are looking at this as being helpless and hopeless, and it's not going to go away, and they're always going to be stuck in their house. There's also a fear that people are going to lose everything because their money is fading away. So there's a lot of worry. Now, worry is different from depression. You see, anxiety and worry are the feelings of what's to come. Depression is feeling stuck in what was. So people who have a lot of worry are fearful that they won't have control over the future and that things will fall apart and there's nothing they can do about it, and they have that same helplessness and hopelessness. There are similarities between depression and anxiety, but with anxiety, we are worried about what's going to come, whereas depression is being stuck in what was. And so this is why we have such an increase in this suicide thinking, not necessarily always suicidal behavior, but suicidal thinking, suicidal ideation is what we call it. We get there? Do we get that person, Sean?
I think so. They'll chat if they have other questions.
Okay. So a person, one of the sort of signs that we might look for is a person who's getting things in order. They're for some reason moving really quick to make out their will, or giving away things that are really important to them, making arrangements, doing something with family. They're afraid they're either going to die or they're thinking they may hurt themselves. I know on Mod 2, those of you who have taken EMS, I got one question right. I have passed the rest of the test, but I know I got one question right, and that is the rapid recovery from depression. That is a sign of suicidal thinking. A person who has made a decision, okay, I'm going to do it, all of a sudden seems like they're not depressed. A person who's been depressed for forever, and then bam, they're fine. This is something that they're not fine, but they feel they're fine or they're acting fine. This is someone who is at higher risk for suicidality. And I was pleased that they put that question on the EMT test, and I know I got that question right. Of others I did, but I know I got that one. People who say goodbye, and I know we had this situation not long ago in the fire department. Someone was just going around and saying goodbye. And it was just, people said it was kind of odd. Why was this person saying goodbye? And no one really, it didn't really register until later when this person was going around saying, hey, goodbye, you know, and this was, unfortunately, hindsight is always 20/20, guys. So don't sit there and judge yourself if you're one of those people who feel you missed it. It's always easier to Monday morning quarterback and say, well, okay, that might have been a sign, or this might have been something I could have paid attention to. I remember my first suicidal case that I worked on. I was working at Taylor Manor Hospital, and I was going down the hallway, and my job was to continue to check on all the different patients in each of the rooms. And I walked into one room, and this patient was doing quite well, sitting on the side of the bed and reading. Hi, how are you doing? And it was a positive conversation. I walked out, went to the next room, and just a few minutes later, I hear a scream and someone hits the panic button. That person had hung themselves from the sprinkler system in the hospital. They bring in the psychiatrist to talk to me because I was the last person in there, and I was upset about that. And probably was about early 20s, I guess, working at the hospital. And the psychiatrist said, are you blaming yourself? And I said, well, I was the last person to see this patient, and I don't know what I missed. And the psychiatrist said to me, you will spend so much energy, so much time thinking about what you missed. You can't Monday morning quarterback all of this and think about everything, because you might not ever know if there was something you missed, what you might have missed. I was like, well, but she was sitting there. Was that a sign? And as the psychiatrist said to me, you're not always going to be able to tell what the signs are. But one of the things that, after this chat, you might come to understand is someone who's just walking around saying goodbye, goodbye. If I don't see you again, it's been nice, goodbye. Oh, and I want you to have this from my locker. Those are people who they're in a difficult place. Someone who withdraws. One of the greatest things I have seen in several of the firehouses where I have come to hang out and visit people is people sit around the table. I think it's fantastic. I have had so many wonderful conversations and laughed so hard sitting around the table at these firehouses. But then you have that one person who's kind of withdrawn, who's off to themselves, who goes downstairs and sits in the TV room. And people will joke sometimes, oh, they just don't want to be around us. That, to me, I want to go down and say, hey, how come you're by yourself? What you thinking? What you feeling? So I do want to engage that person. I do agree that you all have a family, this fire family. And so for someone to isolate themselves from the fire family, to me, is something I want to reach out and say, how come you are isolating yourself from the fire family? What are you feeling? And what's going on with that?
There are some more questions.
Sorry, go ahead.
Yeah, so one of the questions, I think, in line to what you're talking about now is if someone completes suicide and nobody picked up on any signs and symptoms, how do we handle that?
I'm going to get to that, in just a few minutes, what to do if you are the survivors of a suicidal person. So if you can, I'm not going to ignore that question, but I'm going to come down to it in just a few minutes. Okay.
There's another question about, are there signs for people to self-evaluate for PTSD? What about when people have delayed response to critical illnesses, critical incidents, or stressors in their lives? Will that be a little bit later?
That I'm going to get to PTSD in just a few minutes.
Great, thank you.
So just so you know, the flow I'm trying to work through is so that you understand sort of where the suicidal person may be and how to identify if someone may be at risk. Then I'm going to go to post-traumatic stress disorder and depression and how that will, how that can trigger suicidal ideations, suicidal behavior. And then I'm going to get to how to be the person who survives the suicidal experience, someone committing suicide. Okay?
Before we pick back up, thanks for that outline. Can suicide occur during a psychotic episode?
Yes. Remember that a person who is in a psychotic episode is having a thought disorder, right? They're not clear and they're not clearly thinking. They're not logically thinking. So yes, you can have that. Okay, but yes. Were you going to say something?
Yeah, and then someone else about what you're talking about just prior to that. I know you spoke about people being distant. What about people that seem completely fine?
Well, anybody who tells me they're fine, I'm going to ask them, what's that mean? Because you know, you've just been on a really difficult trauma call, and we come back and you say, I'm fine. I have seen many of you who have this big bravado attitude. I'm fine. This is, you know, it's all good. Yeah, you know, you keep burying it down and burying it down. I have seen paramedics, I have seen EMTs, I have seen people in the fire service who have been hurt so bad, and they keep repressing it because they're told you're supposed to just be fine. You know, everything is good, but you keep holding it in, holding it in. Eventually, you can't hold it in anymore and it explodes. And that's when people get into trouble. Okay. So on the outside, people look fine, but if it's not expected that it would be fine, have that, and I'm going to go back here to those of you who are recent EMT people. I'm going to pick up on what you said. Have that index of suspicion. How's that, Sean? Did I remember my reading in textbook? There's that index of suspicion that says, you know, you shouldn't be fine. So if you're telling me you're fine, let's talk. Okay. And someone who says to you, I'm fine. Yeah, let's talk about I'm fine. Right. And those of you who are married, how many times have you come home and you said to your spouse, hey, what's going on? Why are you looking like that? I'm fine. You know, they're not, I see a couple smiles. You know, you're in deep doo-doo because it is not fine. That's when you want to run for the door and go, I'll see you later when you're really fine. Okay. So when someone says that, they're not fine. And if someone's having a psychotic episode, they're not fine, and they're being irrational, and in their irrationality, they can do things to hurt themselves. Okay. People who are heavily engaged in self-destructive behavior is also one of the signs of concern, whether it's heavy alcohol use, heavy drug use, unsafe sex, running around. I've been involved in some cases where someone was HIV positive and they went around trying to infect as many people as they could. And these are people who don't want to live, who are trying to, they have sort of a death wish. And this is a concern. And I talked to you all about the sudden sense of calm and everything seems fine. But let me move on to, if everybody had their video up, I would ask you whether you are familiar with country music. There's a wonderful country song called The Call. And it's a great song. If you haven't listened to it, go to YouTube, put it up, and it's the best song about suicide. And what it is a series of different vignettes where someone was sitting there on the verge of committing suicide and the phone rang. and someone called. And the most important thing that any of us can do, if we know someone is hurting, call. That call, well, it can save someone's life, just to know you care. I can tell you personally myself, there are times I will sit with my phone and there are some people I just want to say, thinking of you. And whether I do it by text or I do it by call, I think it's something important to let someone know you're in my thoughts, you are important. Because when you're feeling helpless, you're feeling hopeless, you wonder if you matter to someone. I don't know if anybody has gone to see the show Dear Evan Hansen, or you've heard the music from Dear Evan Hansen. It's a story about a suicide, and one of the things it says is, if you're ever feeling alone, there's somebody there who will help pick you up. So it is important to call, to reach out to someone. It is important to say to somebody, if you feel that person is kind of down and they are not being in a good place, it is important to say, hey, let's get together and do something. It is important to reach out. It's important to help them, maybe even do brainstorming. It's important to help that person figure out some problems and some ways out of their situation. Because here again, as I said earlier, they can't find their way out of it. They can't figure out how to get out of that situation, how to think their way through it. Are we okay, Sean? We good? Okay. Let's go to post-traumatic stress disorder. Post-traumatic stress disorder is not a sudden occurrence following a traumatic event. It is something that happens over time, that builds. It's a person who may be stuck in that experience of trauma, either a single trauma or multiple traumas. It is a person who isn't able to let go of that trauma and they're stuck in it. The brain can actually, we have something, and those of you who are medical, we have this thing called neuroplasticity, where the brain kind of changes how the synapse function. The brain kind of changes how the chemicals function, and it can almost get reconditioned once there is a trauma to get stuck in that trauma, which some people believe is what is post-traumatic stress disorder. So the whole idea of PTSD, post-traumatic stress disorder, is a component of depression because the person is stuck. They're stuck in that trauma. So let's talk about some risk factors for post-traumatic stress disorder. The Diagnostic Statistical Manual talks about this as living through dangerous events, traumas that threaten your life. But we expand that a bit more because we also recognize it's not just where you feel your life has been threatened, but where you have seen life threatened, where you have seen significant trauma, you have experienced significant trauma. Also where there's a significant history of mental illness. This also can sort of deteriorate the defenses and allow a person to be more subjected to recurring trauma. There is cumulative stress, where you get emotional assault after emotional assault after stressful and emotional assault. This can lead to you yourself or someone having a post-traumatic stress disorder. It is after the trauma happens, and this is what happens with people when there's more and more negative and traumatic events. Not something where you've fallen down, you hurt your knee. You're not going to have a post-traumatic stress disorder from that. But where you have experienced a significant traumatic event, seen significant traumatic events, be around significant traumatic events, this is what causes post-traumatic stress disorder. Unchecked, yes, this can lead to depression, worsening PTSD. And on top of that, there are people who have post-traumatic stress disorder. It becomes so severe that they contemplate suicide, and some have actually, unfortunately, succumbed to suicide. There is this sort of feeling of tremendous fear that there's a difference between remembering a negative event and what we call revivication, living the event. People who have post-traumatic stress disorder, they're not necessarily remembering something that's happened. They're living it again and again. They feel like they are right back there. They can smell it, they can feel it, they can see it lively right in their mind. This is what differentiates post-traumatic stress disorder from a sense of, gee, that was a crappy call and I remember that. And we just talk about it. People who have or seek little social support have a higher probability of post-traumatic stress disorder. And as I get into what to do about it, reaching out, talking to someone, reaching out to someone who has gone through a traumatic event, or you yourself having these feelings lead to this post-traumatic stress disorder. My brain just kind of froze because I was going to go somewhere else really quick and didn't want to do a tangent. When a person feels stuck, that post-traumatic stress disorder, a way to help that person get out of being stuck is to talk to them and give them the opportunity to talk and to hear and to process things in a different way. If there are multiple stressors in a person's life, and then on top of that, they have traumatic events that go on, the unfortunate part there is that makes them more susceptible to a post-traumatic stress disorder because their defenses are already weakened. How are we doing, Sean? Any questions that are coming up so far?
Nothing new. We are close, I think, to the question about what are the signs to self-evaluate for PTSD.
Okay, so
what and when people have delayed response to critical illnesses, incidences or stressors in their lives.
All right, so self-diagnosis. First of all, armchair psychology is very popular. Let's be careful with self-diagnosis. However, with that said, a person who's having recurrent nightmares, a person who is having revivication, where you are experiencing yourself as being there, a person who feels themselves to be highly agitated, irritable, snippy, snappy. These are people who are subjected or who are experiencing some symptoms of post-traumatic stress disorder. If you've had a lot of stressors and you find yourself being worn down, tired, avoiding social relationships, avoiding family relationships, secluding yourself, isolating yourself. And I'm not talking about right now in this whole COVID-19 thing, but the whole idea of secluding yourself, being away from people, getting a lot of headaches when you're around people, feeling irritable when you're around people, not being, feeling like you're losing your patience. Now, that doesn't mean that when you get home and your kids are really being difficult and it's getting on your nerves, that now you say, oh, well, I'm having post-traumatic stress disorder. No, you've got to put them all together. It's more than just, I'm having a bad day. It's reliving the events. It is being, if I can say it this way, haunted by these traumatic events. It is irritability in the relationships. Those things put together, when you start to see that, you start to get a lot of stomach aches when you're maybe going to work and you're constantly feeling nauseous when you're going to work, or you're calling out sick a lot, or you're going someplace, you're drinking a lot more, you're doing, well, I know no one in the fire department does drugs, but someone who might be doing more drugs, they're more inclined to be saying, hey, I've got a post-traumatic stress disorder. So I think that's one of the things or those are some signs that if you are experiencing those, you might want to question it. And then reach out to somebody and say, okay, here's the things that I'm having, and somebody can go down this with you. A clinician can go down it with you and talk about this is this is what you're going through. Is it or is it not a post-traumatic stress disorder? There are resiliency, and one of the biggest driving movements right now is talking about resiliency, because that's what keeps people from becoming affected by post-traumatic stress disorder. And those include talk to people, ask for help. When you get back from a bad call, talk it out. I can't tell you some of my really funny experiences sitting around the firehouse, but you all know that firefighters can have very, very sick sense of humor and laugh your butt off at really sick jokes that no one outside the fire department would ever laugh at, but they do. And that's a way of increasing your resiliency, is talking about it, laughing about stuff, being with the people who understand. Talking in a support group. I think there needs to be more support groups for fire and EMS talking about difficult calls, not just coming back. And there's one station I can think of where when they come back, everybody kind of disperses to their rooms. People need to stay together and talk out the issues. Compliment yourself, compliment each other. When it's been a bad call, but people have done well on the bad call, they've handled the call. It may not have turned out the way you wanted to turn out, but people handled it well. And by complimenting each other, people feel better about how they did on the call. Even if firefighters and EMS personnel, they're all about saving people. They're all about making it better and being powerful. And they're the ones that they came in, they were the hero, they rescued, but sometimes it doesn't work out that way. But acknowledging the good things that we do in the helping professions helps us feel better, and then we don't have as high a risk of post-traumatic stress disorder. Having coping strategies, whether it's going for a run, writing in your journal, ways of learning from your experiences, negative experiences, these kind of coping mechanisms increase your resiliency. I know we're running close. I don't know what time you all want me to end, but I'm going to get in just a second to surviving when someone commits suicide. So one more thing I want to be able to talk about, and that is being able to act and do things even when you're afraid, confronting your fears. I will tell you that one of my wonderful friends, Chris Santoro, and I will, if he's listening, he'll love this one. I don't like heights. I could not do your job, people, and get up on one of those ladders. There's no way, until Chris decided it was time for me to confront my fears of heights and put me in the bucket on the front of Tower 17 and started going up. And I had to increase my ability to manage that fear. And that when we are confronted with our fears, being able to confront them increases our resiliency to further assaults. So now, let's get to what happens if you know someone who has committed suicide. I frequently get phone calls from people saying, I've got to go to a funeral. I don't know what to say. I've got to talk to the surviving spouse. I don't know what to say. Say hi. Say, I care. If you are the person who has experienced the loss of someone through suicide, people are going to be afraid to come to you, and then you start feeling alone or lonely because people don't know what to say to you. And we all need to take care of each other, both the survivor and those trying to help the survivor. And sometimes you just might say, it's okay that you don't know what to say. Thanks for just coming. Thanks for saying hello. But being able just to, excuse me, it's not Corona, I just talked too much. But just being able to talk to someone and go to someone and say hello, not being afraid to express your caring, not being afraid to express your concern. Reach out to somebody, be there to help them, be there to talk with them, be there to listen. Okay. when someone loses someone, sometimes they say they just want to be alone. Sometimes people who have lost someone to suicide are embarrassed. They feel shame. They may want to avoid you because they don't want to talk about it. You can just be around someone and not even talk about the suicide until they bring it up. People who are survivors, they know they feel awkward. You may feel awkward. And people, we learn to work with each other. And we can even start by saying, I don't know how to say this to you because I know it's uncomfortable, but I'm here to listen if you want to talk. Make contacts, reach out, stay close to people who have lost someone, not just in the initial few days after they've lost that person, but be there. You know, there's people will say, hey, give me a call if you need anything, but mean it. Mean it. If someone needs something, be there. And a month later, reach out to someone and say, hey, I told you I'm here. Let's do something together. So make it clear that you are present. Uh, I speak to a lot of people who are survivors of suicide and of a person who has committed suicide. And one question people, without any question whatsoever, they cannot stand is, how did they do it? You're considered more nosy than you are caring. You know, not who cares how they did it? That person died and it's terribly painful. But many, many people have said, well, how did they do it? Did they leave a note? What did they say in the note? It's not relative to being supportive. It's not relative to saying I care. It's more important to say, how are you? Um, it's more important to say, talk about your loss. And what's even better is talk about the good things that you remember. What can you tell me about your life? What can you tell me that's happening for you? I'd like to listen to you. Um, People often are uncomfortable with suicides and going to funerals. Um, Remember that suicide isn't the only thing about that person's life. There are other things about that person you can talk about. It's not just about suicide. You can talk about vacations that person went on. You can talk about other things. Yes, the person you're talking to may cry and it may be sad, but it's also helping that person know that that person who died is more than just suicide. We can't be afraid of people's tears. People are going to cry, they're going to hurt. And part of our job as the supportive person is allowing them to be tearful. And speaking to the people who are on here right now who have lost someone to suicide, it's okay not only to be tearful, but to be tearful around other people. And one of the most important messages I think I give to people who are going through this, or any kind of death, any kind of loss, the number of tears is equal to the amount of love. Crying is not a bad thing. If you feel tearful, cry. Remember that crying is equal to the amount of love. So if you cry a lot, it's because you love a lot. So allow yourself that crying. And if you're with someone who's crying, you know, we're all so afraid of, oh my gosh, I don't know what to do. You're crying. How do I get this to stop? I'm so scared of it. Let them cry. And if it means going through a box of tissues, get a second box and keep going. People need that expression of love, that expression of pain. Be okay with the crying. Let them keep going. There's a lot of uncertainty. There's a lot of questions and doubt around suicide. We all have to be comfortable at some level with uncertainty. We don't know everything a suicidal person went through. Even if they've left a note, we don't know everything a suicidal person was thinking. They weren't thinking when they did this. As I said to you, their logic mechanisms have totally shut off. So we have to be able to accept not knowing and the uncertainty and the doubt, and just know that that person was hurting to such an extent that nothing at that time they could see was helping them. And all we can do is accept that part of them. Sean, how are we doing with questions? We okay?
Yeah, there are no other questions yet.
Uh,
I
I
would
hope,
just really super quick add that Ashley posted for everyone in the chat the link to make sure that you sign in and get your credits.
okay, very good. All right, so another thing that's important, regardless of whether this is a suicide, a death, help with some practical things. Reach out and be there for someone. Be present. People need to know they're not alone. And it's not just for the few days after the suicide or the few weeks after the suicide. It is ongoing. We're really great as a society being present for someone immediately after a death. But in time, people sort of drift away and they get on with their lives. And I have heard from so many people, well, I'm by myself now. You have to be present for people. We all need to be present for each other. There's a Dr. Jordan who talks about the grief being unpleasant and that it's supposed to be short-lived. It's not. You grieve for a lifetime. It becomes a part. I don't know if you all are familiar with the kind of artwork where little tiny pictures, I think it's called a mosaic, but little tiny pictures make up a great big picture. That suicide becomes a part of that big picture. It's just one of those little tiny pictures. It's always a part of that person's life, not as a stigma, but as a pain that they went through. And all of us have those little tiny pictures, some good, some bad, but we all have those. And the last thing I want to say to you is it's okay to remember important events in someone's life who's committed suicide. It's okay to remember their birthday. It's okay to remember them on the anniversary of their death. It's okay to remember them on your wedding anniversary. Remember that calling the person who has gone through that loss, they're already remembering it. So don't think that you're bringing up something they may have forgotten. They haven't forgotten it. But you being present, all of us being present at the time of that loss, gives that person that extra bit of support. So I will now leave that to questions. I'm hoping I answered some questions for people or some of this was helpful. What questions do you all have and how can we best help you?
How about some contact information if folks want to connect with you offline?
With me? Okay, so you just reminded me, I'm going to bring it up here because I completely forgot to bring it up. Again, I do want to remind you all that oh, I'm offline. Hold on one second. I unplugged my computer to plug this in. But so my phone number, if anybody needs to reach me, is 410-628-2121. My email is dr.kirschner@lifemasterycenter.com. And I wish that somebody would have helped me know how to put something at the bottom of this screen. But if I had it, I would put this phone number, which is the National Suicide Prevention Lifeline, 1-800-273-8255. 1-800-273-8255. I do want to let you guys know that hopefully in every firehouse there is in Baltimore County, there is a phone number listing of all the Schism members. If it's not there, by all means, give me a call Chris Santoro. We will happily get you that listing to put in your firehouse in a very obvious place that people can see. It has phone numbers for all of us on the Schism team. It also has important numbers, crisis numbers that you can use if you need them. But do write that phone number down. 800-273-8255 is the National Suicide Prevention Lifeline.
So I put your email, your phone number, and the national hotline number in the chat.
Okay, very
good. And then what about people in terms of in the fire service, if you're concerned about another member or if you have your own concerns, how do we escalate that in a safe way within our ranks, within the fire service?
There are several different ways. Firstly, if it's yourself, reach out and say, hey, I need help. Whether you call EAP, whether you call your physician, whether you call a mental health professional, whether you call me, Sean, you reach out and know when you reach out, there's going to be people whose hand will be there to catch you when you reach out. I encourage you strongly, if you're in that place, hopefully this Zoom thing will allow you the opportunity to understand you're not alone. You don't have to be alone. There are people who will help you figure out ways to manage some of this feeling of helplessness and hopelessness. And if you know someone who is struggling, once again, number one, I would go to that person and say, I get it. I hear you. Talk to me. What's going on? Please don't be shy. There is one, or there's two, but one very important way that I am allowed to sort of break confidentiality, and that is if I feel someone's in danger of hurting themselves, I'm going to take action. And that might be, I'm going to come to your house, or I'm going to send somebody to your house, or I'm going to send the police for a well check because I don't want you to die. And I know that you don't want to die. So I just need to help you figure out other ways of managing this helplessness and hopelessness, other ways of managing this hurt, because I know you really don't want to die. You just want to stop hurting. And that's the way I would do that. Whether it's yourself or someone else, I'm going to find ways to reach out to you and find others who can reach out to you as well.
There's a question about, can you talk a little bit about anger towards someone who has completed suicide?
A very normal reaction. There's not much more to say. You stole something from me. I am angry with you because you did something to me. I am hurt that you did something to me, and I am angry with you. And I have had people who come to therapy and they write the most angry letters at the person who has committed suicide. And I've had them take it to the graveside and burn it on top of their grave because they're so angry. They need some way to express that anger. Your anger is very normal. Your anger is extremely acceptable. And yes, you're angry and you have every right to be angry. I wait for the person to come in and say, I'm no longer sad, I'm angry. And then that's part of the movement. Remember the stages of death and dying, and anger is one of the stages of death and dying. And it is very important that you know it is perfectly reasonable for you to be angry. I'm waiting for it. When a person comes in and says they're angry, I'm, okay, good, we're moving forward here.
What other questions do you guys have? Somebody asked who the artist is playing the piano in the background.
Oh, in my office, I have a YouTube channel up here, and I just like the quiet music. So I apologize if that's been overwhelming. I could have turned it off, didn't think about it. I wish I could play piano. I am working on playing. I don't know if Alan Rudy is here anywhere, but I am still practicing the bagpipe. So it wouldn't sound that good, I can guarantee you.
Alan is online.
Alan and Kelly, I'm practicing the bagpipes. Even in this time when I can't go see my my bagpipe teacher, I'm still practicing. Other questions from anyone? So let me close by saying, firstly, thank you all for being here. I'm hoping this was a helpful chat for you all and that you got something from it. I know that suicide, depression, PTSD is a very, very prominent concern in the fire service. And I think if we all work together, understanding it, reaching out to each other, being together, we can really eradicate depression and suicidality and PTSD within this wonderful family that you all share together. If you have questions, if I can be helpful in any way, Dr. Sean has put my information on your chat. You're welcome to reach out to me. Anyone on the Schism team, any of us, or any mental health clinician will always be there to help you.
So we're getting a bunch of comments about how so informative, and thank you so much for your time. Ashley resent out the link for sign in, and then there's another question. Did you talk about protecting the person is not the answer?
I don't understand.
So I guess it's about protecting the person who completed suicide, right? Yeah, is there any tendency to kind of protect that person or not talk about that?
Because there is that shame, and I talked a little bit about the shame, that people feel a sense of shame. And I think it's how we talk about it. If someone is hurting, the way we talk about it is, someone's phone call is coming through your chat. The way we talk about this is, this person was hurting so bad, they did not know any other way to express their hurt. So instead of us feeling shame or embarrassment or needing to protect them, we need to understand as much as we possibly can, because we feel that hurt and we feel that anger. They did not know any other way to stop their hurt. The other side of that is people who feel guilty because they didn't recognize that person was hurting so much. We can only do so much. We do everything we can, but we can't be the total fixer. And sometimes you couldn't tell what the signs were, and it's not your fault. No one makes another person commit suicide. It is not your fault that someone made a decision to stop their own pain. It's not your fault.
There's a question about how often do you evaluate members of the Schism team? And I'm trying to get clarity on what that means.
Yeah, I don't know what that means.
Yeah, we'll see if she chimes in. Oh, so in terms of their qualifications, how often do they turn over, right?
Okay, so everyone on the Schism team has to go through training through what's called the ICISF, the International Critical Incident Stress Foundation. The Schism team, they are peer support. If a person is struggling, they will be there as a peer, and they may help you connect with a mental health professional if your issue is something that is beyond the scope of just a peer support. So they are not mental health clinicians, and we're not evaluating them to be a mental health clinician. We are present for you as a peer. And I keep teasing Chris that not only am I a doctor, but soon I will be a peer, because once I get this EMT. But the rest of the people on this team, there are 2 other mental health clinicians, but they are not mental health providers. They are peers who care and are there to listen, and if need be, help you get connected with a mental health provider.
Hold on one second. There's more questions. How do you handle providers who you see that are in need of help, but they keep saying they're fine and they refuse help?
Providers meaning fire specialists and EMT people, or mental health providers? Who are we talking about? Because I'm using the term provider as mental health.
Yeah, I think we're talking about.
I'm fine. No. Are we talking about how do we handle EMS and fire personnel?
Yeah, our colleagues, right? Our colleagues who you think are really in trouble, but you keep addressing it. They say they're fine, and they really don't want help.
That's when you invite Dr. Dean for ice cream.
Oh.
That's when I come over and I go, okay, I understand that you say you're fine, or, there are not just myself, but I'm sure other Schism members who have gone to different firehouses and will stop by and say hi. And why don't we all sit down together and talk, because you do care. Here again, this is not a time to be shy. If you feel someone is in trouble, by all means, walk up and say, you know what, fine, ain't working for me. Have a seat. Let's have an ice cream together. I've got some thoughts about this and feelings. It doesn't feel like you're fine. So be open, be honest. You showing you care is wonderful. It is not objectionable. And that person might laugh at you, and I can tell you, a lot of my friends are going to come back with, I'm fine after this chat. I can guarantee you. And I'll come back to them and, well, then let's have a conversation. Because I'll tease right back. But one of them might be saying it in a way that's, hey, doc, can we talk? I'm never going to dismiss it and just go, it's a joke. Let's talk.
Can we get some training on what to expect from the Schism team when they are called out?
Can you get some training? Okay, so the Schism team is there to assist people in the management, expression, processing of a difficult call, allowing people the opportunity to process that difficult call in an attempt to mitigate, to lessen the psychological impact, the long-term psychological impact of a traumatic call. To give people the opportunity to talk it through, understand what they couldn't do, give them the opportunity to express their feelings, again, to decrease the likelihood of this becoming a significant post-traumatic stress disorder. It doesn't obliterate that, but our goal with critical incident stress management is to learn some skills, teach some intervening skills to help people in their immediate need to manage the effect of the exposure to a trauma.
So what could providers expect for them to do? So what can providers expect for the Schism team to do for them when they show up after an incident?
Okay, so you can expect there to be either a one-on-one, you sit with one single provider, or the group sits down as the entire team who was on that call, and you will go through the call. You'll talk about what you saw, what you did, how you felt, what you experienced, and it gives you a sort of a cohesiveness. It also clears up misconceptions of what somebody might have seen or experienced. It gives everybody the opportunity to process that call together. Also to understand something called universality, that everybody is together in this. You're not isolated, you're not alone, but that there are others who experience this with you and can join together. You remember I said to you that one of the most beneficial aspects in the treatment of depression and post-traumatic stress disorder and the decrease of suicidality is to be able to talk with others who have similar experiences, who understand, who get you. So in a Schism process where you have peers, these are people who also are firefighters. These are people who are also EMS personnel who can talk with you and understand. My friends in the fire service have made a very, very wise and very meaningful suggestion when they said, I really should ride on an apparatus to see what you see, to be around what you do. It really has changed my entire career and how I've been working with first responders for years. But when I finally started to ride with you all as a peer, I can see what you see. It has given me a different impression as I sit and work with you. And that's what's beneficial about having a peer support. If it gets to be to the point where a provider of Schism cannot manage whatever's coming up, they will reach out to a mental health provider or help you to reach out to a mental health provider to help you in that.
How does somebody, if somebody wants to help and get involved with the Schism team, are there opportunities?
There are. You would reach out to Chris Santoro, and he is the program manager, program director for the Schism team. And he would help you to do the application and get engaged in being able to reach out for others.
How do we find him?
Hang on. Let me see. Chris, if you're on here and I'm giving out your email, tough because somebody asked for it. Okay, wait a minute. I thought that was good. Hold on. Contacts. All right. You ready?
Yep.
Schism Chris, CISM Chris, CHRIS @gmail.com. schismchris@gmail.com.
Got it. I sent that out. So yeah, now questions are really pouring in. Okay. So what should you expect from the Schism team if you have the death of a shift member or suicide of a shift member?
Well, what can you expect? Hopefully, you're going to have a Schism member come out and do what we would call a debriefing and talk about it, give you the opportunity to talk about your feelings, educate you on how to take care of yourself, and kind of help you to figure out what you need, if you need just to share your feelings, if you need to talk about the anger you feel, talk about your confusion, and to be present for that. And then if need be, to help you connect with someone if it needs to go to a mental health provider rather than a Schism team member. Remember that Schism is not the be-all for mental health concerns. It is to help with the immediate need to help people get through this traumatic event as best as possible. But Schism members are not, they're not mental health providers, and they're not there in substitute for mental health providers. They're there to help people in the immediate need to help address a traumatic event.
And I presume it's okay. I can definitely understand how at times people may not be ready to talk about that. They may feel like, yeah, they just need some alone time. And
Sure.
that's okay too, right?
It is okay. I'm a little bit cautious about saying, just take yourself off in the corner. If I see someone isolating, I'm probably going to go up and say hello. I'm probably going to go up and say, hey, so this hurts. Let's talk about it. Because I'm of the belief, in my world as a clinician, I'm of the belief that the more we talk things through, the less they're held deep inside, the less likelihood of depression, the less likelihood of feeling stuck and hopeless yourself. Because, and I've used this analogy many times, so if I've already said this, I apologize. You all know what a boil is. A boil is an infection under the skin, and it's bacteria that got down deep inside and it eats at the flesh. You have to lance it in order for it to heal. It might hurt to lance that boil, but the only way for it to get better is to lance it and squeeze the disease, the infection, out of that boil. It's the same thing with our mental health trauma. We've got to let it out. We can't keep it all inside, because otherwise it can get very sick and very diseased deep inside of the body and cause even greater concern and injury.
Somebody even attested that you'll bring the ice cream.
I have done that. I particularly like Klondike bars.
I think that's about all we have in the chat right now, Dr. Dean. Oh,
Okay.
Talk about Baltimore County Fire Department policy about the confidentiality of the team.
Okay, our team is strictly confidential, and people must sign a confidentiality understanding that what is talked about in these meetings is strictly in this meeting. People are required to be in, required to maintain confidentiality as a part of this team. This is not a team to hurt anyone. It is a team to help people and to be there for, I can tell you this team is deeply dedicated to the health and well-being of the fire service in Baltimore County. I know that. I have friends who are on this team, friends who've been on this team for many years, who care deeply about you as a fire family. And they are not looking to talk to you and then go spread whatever gossip. That's not what this is about. It is to help you. Now, is it always perfect? I know that the Schism team does the best that it possibly can. Are there things that we can improve? All of us in the world, yes. But it's not for lack of trying and not for lack of caring.
Well said. I think that's about it, Dr. Dean. Thank you, thank you, thank you. Thank you for taking care of us. Thanks for caring for us. Yeah, thank you.
An honor. Be safe, everybody.
Thanks, everyone.
I will hang out for a few minutes in case anybody has questions.